I don't actually know how you follow that, but so I'm starting this session with a question: who decides? And it struck me this morning, one of the questions was why. So it could be why, but it's for us, who decides to fund countries where women are dying and need help and need essential skills? Who decides which countries are worthy of the money? I was introduced a midwife for over 40 years, and I am a member of ELSA, Essential Life Saving Skills for Africa charity, and one of the group of volunteers who goes to South Sudan every year. And the charity has been doing that every year since 2013, with the exception of the COVID years. And so South Sudan is one of the youngest countries in Africa. It achieved independence in 2011. It has a population of about 12.5 million people. It has a capital called Juba, which is the largest city, and it's where we are based when we are in country. And it is a country that is plagued with political instability, with natural disasters, and some people have concerns or perceptions of concerns for people's personal safety when they're visiting. And so, for that reason, it is a country not on the list of approved countries to visit by foreign offices in Ireland and the UK, which is also part of the reason why it doesn't secure funding, or we have been unable to secure funding. But it is a country where, and if you've seen our stand today, a teenage girl is more likely to die during childbirth than finish secondary school. So you all think of all the young girls you know at the minute in secondary school. And funding is complex, and we've heard and we all know there isn't lots of money, and they are difficult decisions. But in South Sudan, I'm going to get my numbers, I'm terrible at numbers, but it's approximately 3 women die a day in South Sudan, estimated. And it's estimated because we actually don't know. It's not a country with sophisticated systems for counting maternal deaths and deaths related to reproduction. So at least 3 women a day die. But if you compare that to Ireland, where for every 100,000 births, around 7 women will die. And in the UK, where just about 10 women will die per 100,000. Then you get some idea of the scale, some idea of the challenge. And why do women die? Women die for all the reasons we've been hearing about here today. They die because of issues of culture, of gender, of poverty. And they die because of very well-known obstetric complications. And I apologize in advance that I'm a midwife, so I really don't have enough discretion about some of the things I like to describe. I have a son who constantly tells me it's inappropriate, but there you go. But women die because of hemorrhage, so bleeding heavily following birth or during. They die because of high blood pressure, eclampsia. They die because their labours become obstructed, the babies can't deliver. They die because of infection. They die because of miscarriage. But they mainly die because there's not enough skilled health professionals to provide care for them. And hospitals in South Sudan exist, but they are not necessarily accessible for women because they are expensive. And by the time the woman arrives to a hospital, often the complications are far advanced. And of course, the journey to a hospital is extraordinarily difficult. So, with my colleagues, we've been invited every year through long-established partnerships and collaboration with colleagues from South Sudan, and haven't secured a memorandum of understanding with the Ministry of Health, because actually you just can't arrive into people's countries and say, just see us here, we're here, we've arrived. So having all those people on our side and them asking us to come frequently throughout the year, we do a risk assessment, we plan, we take account of what's happening in country at that time, and then we go, usually about 8 of us. And we go to deliver a program which is very much skills-based. So I would like to say it's a bit like this, but actually it's much nicer than this, just putting that out there. It's really getting midwives, doctors, clinical officers to come and learn skills, because equipment isn't always the answer and it isn't always available. Our program is 4 days long. We run 2 programs in 2 weeks, and we generally have about 32 participants per program. The demand for the places on the program is extraordinarily high, and it's difficult because you have to turn people away. Nevertheless, to do workshops, to do tabletop exercises, videos, practice sessions, discussion groups, with some lectures in the middle of it, does require not to have huge groups of people so that we can absolutely supervise and repeat and engage. And so one of the things that people have often said, especially because of COVID, is why not use the technology we have now? And we've heard a lot about climate change. Why travel to South Sudan? And the answer is that for the participants that we've worked with, they believe that they get more value out of having face-to-face sessions. They don't have reliable internet. They don't all have phones. The batteries run out. It is an extraordinarily difficult environment for them. And so for that reason, we continue to go. And when I was preparing this story, I was thinking about it, and I thought, well, actually, we are talking about skills-based training, and how many people here would let someone drive a car, having completed some simulation suites, and then perhaps a few YouTube videos? I don't think many of us would let people drive cars in that circumstance. And so for us, we are trying to work with individuals who are already in difficult scenarios, to support them to develop the skills and to leave us with some confidence in the skills they've acquired. And it's the participants themselves who come, who really, really make the difference. Their thirst for knowledge is extraordinary. And they come to us, and unlike other organisations, we do not have money. We fundraise, we cake sales, we buns in church halls, students raise money, lots of people raise money for us to come. And with that money, all we can do with it is provide a meal each day. So no pens, no t-shirts, no travel funds. And for many, particularly the midwives, they're coming from quite distant rural areas. And they come and they will stay with friends or family. And the staff who work in Juba Hospital will actually often work shifts around so that they can come during the day to our programme but continue to provide care outside ours. And when they come, they are so supportive of each other, first and foremost. So, for example, last October, in the 2 weeks, we had 5 midwives who came who were nursing babies. And trying to do practical exercises like, resuscitation, doing the staying alive, you've got that, you've done the CPR. With the baby tied on your back is not easy. And so it's been inspiring watching the way others will lift the babies, nurse the babies, care for the babies, to allow those mothers to fully participate. In the same way that it's incredible when you see colleagues who notice when someone doesn't read English or doesn't speak English and translating for them automatically because of their desire to get the most out of the situation. But just because we're there doesn't mean that we don't learn. We learn a lot. I bring back a lot to the student midwives that I teach. Issues about culture, issues about respect, about different ways of viewing the world that I have learned from the people in South Sudan. So, for example, one morning, one of the midwives, an older woman, Margaret, came in late. The participants in our program don't come in late. They came in late. She came in late, and Mishkat, who was one of our doctors who was helping facilitate, explained when Margaret was apologizing to us for being late that actually she'd been up all night with Mishkat, and they had looked after a woman who delivered triplets. Triplets haven't been mentioned here today already, but actually delivered triplets in the hospital beside the teaching centre that we're in. And we were really astounded because in the UK and Ireland, you don't see women delivering triplets. They have a caesarean section because that's our answer. But they have not lost skills that we have long neglected. On the other hand, one of my colleagues, Gary, was teaching how you manage an inverted uterus. And so for the people, again, who aren't from clinical backgrounds, an inverted uterus is where the womb turns out inside out following the birth of the baby, and the mother hemorrhages profusely, and it is a massive obstetric emergency. And John, one of the young Sudanese doctors who was on the program, said, "I wish you had been here last year and I had been on this program because my sister died last year of an inverted uterus." So the things we teach are real. We had Rabina who came in one evening and said, or one morning and said, "Oh, I got to practice the skills of how to deliver a baby whose shoulders were stuck, a condition called shoulder dystocia. And it was good because we had practiced it the previous day." So those are things that we learn. But we also learn that in UK and Ireland, women from black and ethnic minorities have a higher rate of death than Caucasian and local women. And the reason is partly to do with culture. Because as one of the midwives, Lillian, explained to us, in South Sudan, we talk about choice, empowerment. We use those words all the time. The women don't equate with those words. They don't relate to them. Because as Lillian explained, her husband paid a price for her. He is the decision maker. Not from a bad place, but from that's the structure. So in the event that a woman needs a caesarean section or expensive antenatal care, the man has to decide, can we afford it? And that can be a decision that is life and death. So you can imagine the trauma. So I'm always mindful now, I've said to the student midwives, the midwives I work with at home, take account of what the woman's understanding is. Don't use words like choices and empowerment as if they are familiar to everyone. And so the other issue for us is, however, sustainability. Going to South Sudan is great. Most of us in the team will regret me saying that none of us see 50 again, so we're not getting younger, and it's where the future is and how the program becomes sustainable and self-sustaining. Over 500 doctors, midwives, clinical officers have been trained. Within those numbers, we have tried to identify a number of people to become facilitators, people whose skills shone out doing the program as having the ability to teach. And so we work with them and invite them to come back to programs in the future to participate and learn so that they can carry it forward. And we provide them with any copies of equipment and USBs, anything we have that's helpful. And they come so willingly. Margaret is a midwife who now works for MedAir. She uses her leave to come to help. And so we feel at least we are trying to fill a gap, but we do realise that it is very small, very, very small drops in a big ocean of need. But nevertheless, every year before we leave, senior colleagues are down with us saying, what date are you coming back next year? What date are you coming back? And so you're leaving going, okay, let's get the dates in the diary. Let's try to find some money in order to get ourselves to where we need to be. And so we will go back, but I would ask you all to remember, who here remembers the Millennium Development Goals? Those goals that said, let's reduce significantly the maternal mortality, improve the outcome for babies. That hasn't happened in South Sudan. In fact, the position is worse. And so my plea today is, let's think about how we decide where money goes and how maybe we can do it differently. And in the meantime, we have the dates in our diary and we are going back in October. And thank you very much for listening.